There is a lot of angst about the cost and appropriate use of molecular diagnostic testing in cancer treatment. Let me first say that our goal is to get the patient on the therapy that is most effective for that patient. And molecular diagnostics and IHC testing allow us to identify which therapies are unlikely to work. And I would say that anytime we give a patient a therapy that's unlikely to work, that's a waste. It's a waste of a potential opportunity to improve their outcome, and it's a waste of resources. I'd also say that this angst about the cost of testing, put in context, should almost be forgotten. The cost of these therapies that we're prescribing may be $10,000, $15,000, $20,000 a month, and that's if it's monotherapy. In combination, it could be significantly more. So the cost of the molecular diagnostic testing to identify which therapy is most appropriate for a patient is a good investment in my mind. In non-small cell lung cancer, we have EGFR and ALK mutation testing, ROS testing that can help identify a patient which therapy they would be most likely to respond to. The question of whether or not we should do broader testing, broader molecular diagnostic testing, is addressed in the NCCN guidelines. In fact, they say that patients should have broad genetic testing to not only identify which therapies are approved for which they'd be eligible, but also to identify patients who might be eligible for a clinical trial. In our frame of reference, being involved in a clinical trial is a good thing for patients. It helps reduce their out-of-pocket costs, it reduces our costs, and in Medicare, for example, in the Medicare Advantage plans, patients on an approved Medicare trial, all those costs revert to original Medicare. So I think there are good clinical reasons and good financial reasons for a health plan to cover the cost of those tests to determine whether or not a patient is eligible. For example, there's the NCI match trial and the TAPER trial. Our plan pays for molecular diagnostic testing for patients to determine if they're eligible for a trial, because we believe if we're willing to pay for the research, we need to pay for the testing to determine whether or not they're eligible for that research. In the formulary approval process and setting up the parameters for approving a drug, we often include the molecular diagnostic test or companion diagnostic test as a prerequisite for getting the drug. If the clinical trials indicate that a patient is more likely to respond with a specific molecular mutation, we'll require that as part of the prior authorization process to ensure that the patients are appropriate for that therapy. Again, if they're getting a therapy that they're unlikely to respond to, it only exposes them to the side effects and the costs without any clinical benefits. It's ironic, though, if a provider wants to prescribe a drug that has a companion diagnostic, we'll make sure that they have that test in order to get the drug. But the converse is not true. If a provider wants to prescribe a different drug, we don't ask the question, have you had EGFR testing or ALK testing or ROS testing? But I think in the next few years, that's going to be standard, that we require every patient be tested so that we know, regardless of whether or not they're getting a platinum-based therapy or immunotherapy or an EGFR-focused therapy, that's the most appropriate for that patient and consistent with the guidelines. The interesting question is, what do you do as a health plan if a patient has molecular diagnostic testing and IHC testing and is an appropriate candidate for both immunotherapy and, say, for example, EGFR test or EGFR therapy? In that circumstance, we'll revert to the guidelines, and the guidelines today don't address that question if you are appropriate for different targeted therapies. So that would be left to the discretion of the physician and what they think is the best balance of outcomes and toxicities.